part is called the luteal phase, and this is where we have the corpus luteum, because it's needed to keep making a bunch of progesterone in order to support this very, very, very early pregnancy. If you get to 28 and you haven't gotten pregnant, and there hasn't been an egg and a sperm get together, and it hasn't started to implant in the wall and all the stuff it's supposed to do, then the hormone levels drop off. It's day 1 again, and day 1 is the day your menstrual period starts. So day 1, let's just say day 1 through 5 is the menses, is the period. Pictures, you're going to have, we got some really nice slides over in the lab of the ovaries and of egg cells. Here, these are primordial cells in here. Let's go a little bit farther. This is what it starts to look like when it's really forming a primary follicle. It looks like this. It's getting all of these, starting to pick up a lot of cells around it. It's starting to develop a zona pellucida. You remember that from the movie, the zona? This is going to protect the egg from those male cells, those spermy cells that are trying to get into it and so forth. The extra cells out here are just called fecal cells in the ovary. This is what it's becoming more of a secondary follicle. It's really, these become really obvious when you're looking at the sliced ovary. This is the, actually the egg cell is right here in the middle. It's this big one here. It's got a big nucleus of the primary oocyte. The zona is around it. And then it looks like this. And these are really easy to identify. They're easy to look at. But basically, there's a big antrum containing a bunch of follicular fluid. And over on one side of it, there is this is the oocyte. It's now a secondary oocyte, visualized right here. It's surrounded by this corona radiata around it on the inside. And this is now called a tertiary follicle. It's in the 3rd stage of development. It's not too far away from being ovulated. This is actually a picture of ovulation. This is the egg right here. You can see these with your naked eye. Okay? And the doctors that are harvesting eggs, either for sale or for people that are trying to do in vitro fertilization, put them in a test tube, mix the sperm with it, and have babies that way, and then take that whole thing and put it back in the uterus below. That's what in vitro fertilization is. But you can see these, and so then they just suck them up with a little pipette. Yeah, that's what I was looking for. And because whenever they do that, they've given the lady a ton of hormones, it's not unusual for her to ovulate 5 or 6 at one time. And then there becomes a bunch of ethical decisions that maybe I don't think I've discussed with you, but think of the lady, you remember the Octomom? I don't know what her name was, but she had 8 children at one time. And she was undergoing in vitro fertilization because even though she already had children, she decided she wanted to have more. And the obstetrician that she was working with was probably not the most credible guy in the world. But anyway, they got 6 eggs. And he said to her, which this discussion always takes place, how many would you like me to implant in your uterus? And she says, all 6. And he kind of thought, well, no, you can't do that. That's too many. She says, but you know, the more you put in, the bigger the chance that even one will make it. And that was her goal, was to have one more child. And so he put in all 6, and unfortunately all 6 of them took and implanted, and 2 of them twinned. So she got 8. And she she held all 8 of them. She was in bed for the last 4 months of her pregnancy, I think, and delivered 8 babies, and all 8 babies made it. And Anyway, he lost his medical license for doing that, by the way. But that's how it happened, yeah.
So my old boss is a twin, but different dads.
Different dads?
Mm-hmm.
Okay.
How is that? Is she releasing?
Well, we'll talk about that when we get to twins. But
Okay.
basically, he's nothing more than a brother.
Okay.
Some ladies throw out 2 eggs.
Okay.
One gets fertilized by this sperm, one gets fertilized by that sperm, and they're just brothers. They're not identical. Identical twins is when the egg and the sperm come together, and at some point they divide into 2,
Okay.
which have exactly the same DNA. But
Okay.
we'll come back to that. Once the egg is thrown out, then that place where it came from turns into a corpus luteum, which looks about like that. You'll see that. And then after you get to the end of the month and it's really starting to shrivel up, it gets white and forms what's called a corpus albicans, which is a white spot on the inside of the ovary as well. Okay. The uterine tubes are the fallopian tubes. They're hollow. But they have all these ingrowths, which you saw in that movie the other day, and the inside lining of the oviduct is very delicate, and that's why so many ladies get, if they ever have an STD, oftentimes the inner lining of their oviduct will get scarred, so the eggs can no longer make it down through the oviduct, and that makes them sterile. And that's why we have the whole business of in vitro fertilization. Because if the egg can't get down there and the sperm can't get up, the only way you can get those 2 together is to do it out in a petri dish. So you suck the egg out of the belly when it ovulates, put it in a petri dish, get the guy to volunteer a semen specimen, you pour that in with it, they get together in the petri dish, it's very romantic, and they fertilize, and then they see how many of them actually fertilized. They let them grow in the petri dish for 2 or 3 days, and then they have a decision to make. How many of these do you want us to put in your uterus? But they come around now to the bottom and put them up in the uterus from below, so they don't ever have to make that trip down the fallopian tube. They put them in from below, and then hope 1 or 2 of them make it. Yeah?
So we had a family friend who did that, but she only had 1 egg and then froze the other ones.
Yeah.
So
for another try.
Freeze them then, and then they'll.
Yeah, you can freeze them.
That's pretty
Wait,
Yeah, it costs like
Get it?
$500 a year.
Egg go.
$500 a
Well, they
year.
make a lot of money. So.
Well, it's a business, and most of the people having IVF, in vitro fertilization, are pretty wealthy, or they have one incredible insurance plan. Let's keep moving along here. The fallopian tubes are just transit tubes. The sperm are going to come up there. The eggs are going to come down. Usually the fertilization is actually going to happen in the fallopian tube and down to the uterus, and it rolls. 3 parts of the uterine tubes. I'm not sure how important this is. Infundibulum is kind of, I think of it as the catcher's mitt. The fimbria are the little fingers at the end of the fallopian tube. And while you might think that there's just an egg thrown out of the ovary up here, and then it just happens to get sucked in here, it doesn't really work that way. When the ovary is getting ready to ovulate, the catcher's mitt comes out here and grabs onto it. So when it ovulates, it doesn't have anywhere else to go except down the fallopian tube. The fimbria are those little fingers. The ampulla is the middle part of the length of the uterine tube. This is the part where the fertilization usually occurs. And then the isthmus is the very last little part right before it gets into the uterus itself. The histology of the uterine tube is important. Lots of mucus secreting cells. It's very moist in there. It's got lots of fructose in there and sugars in there for the sperm to live on, and also for the egg to be cared for as well. A lot of smooth muscle. So you remember I showed you the picture of the vas deferens, and I said, you know, it's this big tube and had this tiny little pinhole in the middle. Well, the oviduct isn't quite that bad, but it's pretty close. Has a number of layers of muscle, and the inner lining is pretty much collapsed all the time. And that's why an infection that gets going in here does such damage to the fallopian tube. I'll just leave it at that. The egg doesn't really swim downstream. The sperms swim upstream a little bit, but most of the movements that go on with these cells are caused by the ciliary movements and the peristaltic, the contractions that occur in the wall to push things down. A few hours before ovulation, nerves turn on this beating pattern of these little cilia, and so all the little cilia get to moving in the same direction to push the spermies up and then push the eggs down. It makes it all happen. It normally takes 3 to 4 days to make this trip from the infundibulum, the mouth of the uterine tube, down into the uterus, and we're going to talk about that 3 or 4 days quite a bit. For it to actually fertilization to occur, oocyte must meet sperm during the first 12 or 24 hours. Now the thing you got to remember, for those of you who think, oh well, I know exactly what day I ovulated on, so I can have sex any other day of the month, right? Because it doesn't work that way, because those guys can live inside of you for a while, a few days, and be waiting. They're kind of sitting there waiting for ovulation to occur, and the eggs can last a while, and so the period of this whole thing happening can actually end up lasting 7 to 10 days, and plus you don't exactly know when you ovulate, and that is why the rhythm method of birth control just doesn't work. Okay? The rhythm method was the only method of birth control ever supported by the Roman Catholic Church, and that's why every Catholic family had about 8 kids, because it just doesn't work. No matter how careful you take your temperature every morning, you count your days, and all of that stuff, it's still a pretty rough estimate. Here you go. Fertilization normally occurs halfway down the tube. Lots of good nutrition going on in here, which is important to both cells. And then we get down into the uterus. So here you've got this fertilized egg that has already been dividing a few times, and so it's getting to be a little cluster of cells, and it gets down into the uterus. And the uterus is going to protect it and develop the embryo for 8 weeks. I'm not sure if this is true or even, I know it's not important, but they call it an embryo for the first 8 weeks. Now the reason they do that is because it takes 8 weeks for it to even look like an embryo at all. And even then, at 8 weeks, it doesn't look much like a baby. And then they call it a fetus from week 9 through week 40, which is when most folks deliver. The uterus is going to provide mechanical protection, nutritional support, and waste removal, all 3, for that little fetus. Here's a laparoscopic tubal ligation. We talked about men getting vasectomies. Well, women can get tubal ligations. Basically, it's done through the laparoscope. You put a little light in there, a little pair of tweezers in here, and usually these forceps have got an electric current running through them, so you go zzz, zzz, and just burn it. And it all turns to, you can see it, watch it turn to white scar. From here, you squeeze it several times. Then usually you cut it, and then you usually take a piece out. Once again, send it to the lab to make sure you got the right thing. Once the piece of tube is out, they almost never grow back, once again, although I'm sure there's cases of it, but I still believe when a tube grows back, it's usually because the doctor got the wrong thing. He got an artery or he got something else, a vein. But anyway, once that piece is gone, then clearly the egg cannot get downstream and the sperm can't get upstream, so they can't get together. And that's a really wonderful form of permanent birth control. I think the most opportune time to have a tubal ligation is right while you're in the hospital having a baby. You have the baby, the doctor says, well, your baby's normal, you want me to tie your tubes? And you say yes, and if he had to do a C-section, he does it at exactly that time. It just takes an extra minute and a half. Cut, tie, done. On the other hand, if you delivered the baby vaginally, next morning you go back to the operating room for 15 minutes through a laparoscope, they tie your tubes and cut a piece out, and it's done.
That's kind of the same story with if this kid doesn't make it and you want to have another.
That's right. If your kid doesn't make it, then you can always just say, no, we'll have another one. But I think there's another question that is probably the overriding question in this modern country is why do we all feel like we have to have babies, as if babies with our genetic makeup are better than any other baby. There's millions of babies out there waiting and begging to be adopted, so think about it for whatever that's worth. Here's a couple of ways to do it. Cut, tie, take a piece out. A lot of guys like to use this loop technique where you basically just pull the thing up through a tube that then puts a rubber band around it, and this whole piece, this whole loop dies and completes the job. Here's a clip, and here's somebody putting glue in it. I'm not sure. I wouldn't sign up for that if I was you. So this is what, these are pictures from a laparoscope. Can you flip the light, Kimiko, just to make it more clear? We're looking from the top down into the belly. This whitish thing here is an ovary. Here's another ovary. This is the fimbriated end. This is the tube going here. The other tube, here's the fimbria end of it. It goes in here. This is the uterus right here. This is anterior up here because this looks like bladder to me, but maybe this is bladder up here. I'm not seeing enough to really identify it. But here they are they've burned a piece of the tube. They've put some clips on it, and they do that on both sides in order to do a tubal ligation on that patient. This is, of course, one of the bad problems with folks who have tubes that aren't working as well as they could, and things get kind of hung up. So some sperm got up, but the egg didn't get all the way down, and the egg tried to implant in the wall of the tube. It didn't make it down to the uterus, but it tries to implant in the wall of the tube. That's called a tupal pregnancy or an ectopic pregnancy. And this is it right here, which is all fine and good until about 3 or 4 weeks. But then it's trying to grow a placenta, and instead of growing it into this nice thick-walled uterus, it's trying to grow it into this really thin-walled tube. And this is the pregnancy. That's the fetus, and all the membranes and the placenta and everything are there in the tube, and it gets bigger and bigger and bigger, and then it usually just kind of busts, or it starts bleeding like crazy. And these ladies oftentimes get run into the operating room to get fixed because they bleed so much. And usually when the tube has been like this, you've pretty well destroyed that tube, and so you just take the tube and the pregnancy out to save the lady's life. Yeah?
Just out of curiosity, is there a way to save the pregnancy with the next?
No, there really isn't, because there's no way to disconnect the placenta, which is eroding into the wall of the tube, disconnect it from that, and then put it back down in the rest of the uterus, which is not even prepared anymore because you're a few weeks down the road. So no, yeah.
You train left the station, you're done.
Train has left the station, you got to start again. I think that's probably a good way to think about it. Uterus is pear-shaped. I always think of the uterus as 2 thumbs. If you take 2 thumbs and put them side by side, that's about how big the uterus normally is. Think about it going from that 30 grams up to this big, right? It's a pretty amazing organ because it can get that big. And normally it bends forward a little bit. That's called anteflexion. In some ladies it's retroflex, it bends backwards. People say that if you have retroflex uterus that it gives you more pain during your periods. I think that's just a way of saying, I'm really sorry you have so much pain during your period. You have a retroflex uterus. And then you've got something you can hang your hat on, right? And what woman wouldn't want to have something to hang all that extra pain on? But I don't know. I didn't do gynecology. I did general surgery. Although we still ended up operating on a bunch of uteruses. The 3 different suspensory ligaments, I've already mentioned them. The uterosacrals prevent the anterior, they're between the uterus and the sacrum. The round ligaments are attached up front and out to the side kind of, and then the cardinal ligaments prevent it from falling out below.
And during pregnancy, those are really stretchy.
They get very stretched, that's right.
That explains a lot.
The body of the uterus is the main part. It ends at the isthmus. The fundus is the rounded portion up at the top. And it's actually, the fundus part is superior to the attachment of the uterine tubes. So if you think about the uterus kind of being shaped like this, and here's your tubes coming off, coming down here like this. This is the fundus up here at the top. Down at the bottom, you've got the cervix, cervix sticks into the top end of the vagina, about a half an inch out into the vagina. You can feel your cervix if you want to. That's what the doctor looks at with the speculum when he looks at does a vaginal exam. And he wants to look at the cervix because that's where he wants to take some cells to do a pap smear on, because cervical cancer is a major cause of female cancer. And if you just scrape a few cells, put them on a slide, that's called a pap smear, named after Dr. Papanicolaou 106 years ago. And you can look and see if the cells look normal, if they look cancerous, if they look inflamed or just infected, and tell a lot about what's going on. The external os is the external opening, and I'll just leave that at that. Cervical canal is within the cervix itself. Those are all in your book. They're easy enough. The blood supply to the uterus does not come from the ovarian vessels, those ones from way up high. Remember, it comes from the sides. It comes from the internal iliac arteries and pelvic arteries. I'll leave it at that. I've already said that. Here we go, back to this one. Nerves of the uterus are basically just the nerves that go to all the organs in the area. Nothing very exciting about them. Sacral segments S3 and S4. Why would you need to know that? Probably because of this reason right here. It's segmental blocks. Did any of you have a epidural anesthetic? Susie had an epidural.
I'm gonna.
There you go. An epidural is, if you remember from our vertebral studies, it's where you put a needle in the back and you don't go through the dura, you stay on the outside of the dura. Through the needle, you feed a little plastic catheter in there, and then the catheter is a really long thing, but you just put it in maybe an inch, and then pull the needle out, tape the catheter all the way up your back. Usually they tape it up to right here, and leave the hub of the tube right here. And so then they can come by, and how's your pain, Mrs. Jones? Here, let me give you a little shot. They give you a little more numbing medicine. It goes in there, it filters up and down through that epidural space. And what you want to do is numb up and paralyze these areas. Now, for an epidural to work, you want it to relieve the pain, but you do not want it to turn off the contractions, right? You don't want it to stop labor. But once labor has started, labor doesn't stop for anything. So you get it started, and then a lady can labor for 36 hours with an epidural in. And after a while, they just hook it up to a pump that gradually puts in a cc or 2 or 3 cc's an hour. And then you just keep coming by and examining the patient. You remember those little segments we studied back in the nerve section? remember the stripes, like you get shingles with? And I remember this was T8, and this was T10 at the nipples. Belly is, I want to say, L4, something like that. No, that's not right. I think the belly is T10, nipples are T4. And so you go along with the needle and you say, can you feel it here? Can you feel it here? Can you feel it here? And you figure out what their level of anesthesia is. And then as they start to go into final labor and they're ready to deliver, you can just juice it up a little bit and numb them up a little bit more. But if they're running into some problem and it doesn't look like the baby's going to make it out, and suddenly you decide, well, wait a minute, we got to do a C-section to get this baby out of here. Then they just give you a whole syringe full, numb up your back, and you get numb from your thighs up here to your chest. But you're still completely awake. You completely observe and watch everything. They put a great big mirror up there so you can see the baby come out. Unless you don't want to watch it. I saw some head shaking. And then they do the C-section, actually make the incision through your tummy, take the baby out, sew it all up, and you never feel a thing. Oh, and you didn't have any gas or anything to breathe. And the thing about obstetric anesthesia that's always been the boogaboo is that whenever you give the mama something to make the mama's pain go better, you put the baby to sleep. And that's the last thing you want to do just before birth. You want that baby to come out and be breathing and screaming and be completely with it. Because he's going to be on his own as soon as he gets out. So that's what these segmental blocks are talking about. These are the nerves you're kind of targeting down there with your epidural. And it can be done with the spinal as well. Yes, ma'am?
So is the spinal is different than an epidural?
A spinal is where you put the needle all the way into the subarachnoid space, through the dura, through the subarachnoid, into the
Because when I
fluid.
got an epidural, it just numbed my legs, but it didn't numb anything else.
Yeah.
And I'm just wondering why that happened.
It just didn't get in the right spot.
Yeah, that's what they said. But I
Yeah.
was like, what's the right spot then?
Well, it probably went out to the side, maybe, or it went too far down. And what they should have done, and that's why you always want to put the epidural in pretty early in the process, is so that if it doesn't work, you can move it, or you can experiment with different volumes to try to get it numb just the way you want. You know, a lot of ladies say, oh, I'm going to have an epidural, and then they get to the hospital and 5 minutes later the baby pops out. Well, they ain't going to get an epidural like that. You know, you need to be there hours in advance and have a regular, sort of a normal progression of your labor. Yeah,
So I don't know what happened when I delivered.
they look like they came out okay.
Yeah, well, she didn't cry, she didn't anything, like,
Did you had any pain medicine?
oh yeah, I had an epidural, but I had been pushing for like 2 hours.
Yeah.
So they turned it off or turned it way down so I could feel, but
Yeah.
when they, like, she didn't cry at all for anything. They brought in the ICU nurse, or the NICU nurse,
Right.
and they had her like pick her up, and she was so confident. She goes, oh, I'll get her to cry, and she picked her up and she let her fall, and still nothing. They were kind of concerned.
Kind of concerned. It looks like it all worked out okay.
Oh, I don't know.
So anyway, moving on here, I think this is the picture, vagina down here, that the cervical os is right here, the opening. This is the cervix. This is called the internal os of the uterus, where it's kind of at the bottom end of the cervix, the inside end of the cervix, uterine cavity, fundus, tubes. I think we've talked about all of that stuff. I always put this question on the test, and I say which is right and which is left, because it's kind of confusing. So you got to think about it. You're looking down into the pelvis. The bladder, you know, is going to be on the front. The colon, you know, is going to be on the back. And then you figure it out from there. Uterine wall, let's talk about it for a minute because it's kind of a magical organ. Has a thick outer layer called the myometrium, which is just the muscle of the uterus, and that's what's going to deliver the baby. But it also has an inner layer, which is very glandular, which is the endometrium. And the endometrium is the part that's really important when it comes to having babies, because this is where that fertilized egg is going to implant into the inner lining of the uterus and take up residence. And when it takes up residence, it's actually going to eat its way into the uterine wall and find a source of blood and sugar and all that good stuff. Perimetrium is basically the outside serous layer, basically the visceral peritoneum, covers the parts of the uterus that show, like you see down there. Endometrium is only about 10% of the uterine mass, but yet it grows and gets very thick, develops a placenta, and meets all the glandular and vascular support necessary for the growing fetus. So the endometrium is in many ways what it's all about. The uterine glands are on the surface of the endometrium, and they extend deep down into the lamina propria, which is one of the layers of the endometrium. Here's kind of a picture of the uterine wall. This is the inside of the uterus out here. This is the endometrium right here. And this is the muscular layers of the uterine wall out here. And this is that perimetrium, or the visceral peritoneum on the outside. Notice that the arteries go into the uterus, the uterine arteries come in from the sides, and they send all these branches down in, and they supply the blood to this inner layer, these spiral arteries. Now those spiral arteries are really important because not only are they going to send all this blood to the uterus and to the fetus eventually, but because they're spiral, they can kind of be cut off by the uterus contracting and make it stop bleeding. It has radial arteries, kind of like the kidney did. And there's 3 pictures here I want to show you, and I'll just tell you right up front that I will not put one of these on a slide and say, what is this? I'll show you all 3 of them at the same time, and then you have to tell me what all 3 are, because I don't think you can really identify them unless you've got something to compare it to. So this is the endometrium. This is the inner surface of it. Most of the wall, of course, is myometrium, is muscle. In here, this is kind of the functional zone. This is the basilar zone, the base. This kind of stays with you from month to month. The functional zone is what comes and goes. Now you may think when you have a period that you're just passing a bunch of blood, but you are not passing blood. What you're passing is all this tissue out here, from there to there. That all breaks off and passes out as a menstrual period. And so it's really, if you look at it, it usually kind of looks like chunks of little tissue. But you can't convince a guy of that. Estrogen during the first half of the uterine cycle causes the glands, the blood vessels, and epithelium to really get going and get juiced up, because the uterus is just like a lot of women. They're just so excited that they might get pregnant this month. And so they get everything ready that they can get ready to have this little fertilized egg come down that tube, land on their piece of the uterine wall, and embed right there, and they can form a placenta and support a new life. It's kind of cool.